Talk about the one of the topic that showed up in the exam and in actual hospital we see the patient usually. So what I'm going to talk about is the intraparenchymal hemorrhage. And in my other video, I will talk about epidural hematoma, subdural hematoma, and subarachnoid hemorrhage. As you guys know that stroke could be two ways. It could be ischemic and it could be hemorrhagic. And it is very important that if we treat the patient as soon as we can. And the first thing in the diagnostic step is always when the patient comes in with the symptoms that you always do the CT scan without contrast to see if there is a bleeding. Because if there is a bleeding, then you cannot do some other stuff that you have to differentiate. Okay, and then the treatment is different between bleeding stroke and non-bleeding stroke, such as ischemic stroke. So now in this video, I'm just going to talk about intraparenchymal hemorrhage. In intraparenchymal hemorrhage, what you're going to see is the mostly patient is going to have the systematic hypertension. So that is the most idiopathic reason that the patient is going to have the hemorrhagic stroke in parenchyma. Hypertension is going to cause the main bleeding. And then you can also see these kind of stroke in amyloid angiopathy. Okay, but in that particular case, you will see the old patient. Okay, and you can also have vasculitis or some kind of neoplasm, some kind of tumor that can also lead towards this kind of bleeding. And it also can be associated with reperfusion injury in the ischemic stroke. So in ischemic stroke, when we try to remove the clot and then when reperfusion occurs after removing the clot in that specific part, that can lead toward the intraparenchymal hemorrhage. Okay, now another name of the hypertensive hemorrhages is called as Charcot-Bouchard microaneurysm. And this is a very specific stroke that is going to be associated with the part of the brain that is associated with putamen basal ganglia. Okay, and basal ganglia is the combination of different neurons that control your choreotic movements, or it is also associated with Parkinson's, is also associated with choreotic movement, or there are different. So the basal ganglia is the one that actually modulate the movement of the human body. So the stroke in that one, you're going to intraparenchymal stroke is going to affect the putamen of the basal ganglia. The second part is the thalamus. The third part is the pons and the cerebellum. In the question variant, they are going to ask you to differentiate between these 3 and 4 different types. So first of all, I'm going to tell you how you can differentiate and what are the similarities between. So again, it's you're gonna see in the question variant, you're gonna see that the patient has a systematic hypertension. Okay, that will be the big clue that there is a kind of bleeding going on inside of the system. And then second, how the patient present is very, very important. If the stroke, as you guys can see here, if the stroke is cerebellum, okay, if the stroke is cerebellum, the patient will present the cerebellum signs. It will be ataxia. There will be no hemiplegia, because hemiplegia is your cortex. Okay, and hemiplegia is your cortex, which is another tract that control that one. Okay, so cerebellum as well also present with the pain. Okay, the neck stiffness kind of pain, or the back side of the pain in the occipital area. And then you're going to also have other nystagmus or other signs of cerebellum. That will be easy to differentiate, but it can be also associated with intraparenchymal hemorrhage. Second is going to be the thalamus. Okay, as you guys know, the thalamus is majority of times it control your sensory, but in this one you will also have both contralateral hemisensory and contralateral hemiplegia. So both kind of symptoms you're going to see. The differentiation between thalamus and putamen, both will have the hemiplegia and both will have the hemisensory loss, because in putamen you will always have the internal capsule involved, which is purely motor. And can all, I mean, internal capsule, the posterior part of internal capsule is the pituitary motor, but anterior or the ganglia part is that one can associated with the sensory loss. So it is very important that you can differentiate between putamen basal ganglia stroke and then the thalamus stroke. So in thalamus strokes right here, what you're going to see is that the eye is going to deviate towards the paresis. So wherever the patient has the weakness, let's say if the patient has the weaknesses on the right side, you're going to see that the eye is deviating to the right side of the patient. However, in putamen basal ganglia, the eye movement is going to be opposite to the paresis. So if the patient has the weakness on the right side, and the eye moves to the left side, because the eye always moves in putamen to the right of the lesion. So if you write on the lesion, you're going to see the eye is opposite to the paresis. So wherever is the weakness, the eye movement is opposite in putamen. That is the differential. In Pons, Pons is kind of very easy because you're gonna see the patient is technically going to coma. Okay, and this is where you are, I mean, more danger. It's like a locked in syndrome. You're gonna have the pinpoint lesions on the one eye. I think that's the end of my video. I will come back with some other. Thank you.